Good morning from Edinburgh. Good morning from Edinburgh, everyone, to the Nursing Now Challenge Global Solutions and AMR Futures Lab AMR Initiative webinar. It's the last webinar in our series. We just wait a few more minutes for people to join before we start. So give us a moment, please. Just double check if you see my screen.
Yes, it looks good.
That's very good. Let's give it another minute for people to join, and then we kick off.
Abdul Ghafoor has still not come in, right?
We can change the order of speakers if there's a challenge with the access. Shall we kick off?
Yes.
All right. Okay. Good morning, everyone, again. My name is Till Bachmann, and I am really delighted for you to join us at our final webinar on the Nursing Now Challenge Global Solutions and AMR Futures Lab AMR Initiative webinar series. Today we have a fantastic lineup of speakers again, and I will soon hand over to my colleague Manish Paul to introduce the speakers and to kick off with the program. And before we do that, I would like to just briefly again introduce the challenge and the Futures Lab as a background for why we're here today. So just on the AMR challenge, we're here because antimicrobial resistance, we all know about it, but to bring us really at the forefront of understanding why we come together in this constellation. So AMR is really a wicked problem. It spans the whole One Health domain, this human, animal, plant, and environment. And it's captured with social, economic, political, and cultural context. And it's really important to understand that simple cause and effect considerations do not adequately create sustainable solutions. Global efforts on to curtail AMR through R&D have received substantial funding, and you see here the numbers. It's substantial funding went to AMR research and development to tackle it. The problem is that most R&D projects do not make it through to the many valleys of death from basic research and development to implementation, and then finally to have some impact. In order to tackle that, we started the AMR Futures Lab, and here's our mission. So we strive to catalyze holistic solutions to the AMR challenge by leveraging ideas across the full spectrum of AMR stakeholders, from people with lived AMR experiences to innovators and implementers to spark the unexpected and achieve impact. In other words, we take the full extent of where AMR is an issue all the way to the innovators and the implementers. The last mile problem is addressed through this challenge by involving the implementers from the start. And this is why we're here today, because we see nurses and midwives as major factors, major stakeholders as implementers. Now, the Futures Lab sits at the Edinburgh Futures Institute. It's a new institute in Edinburgh University, which is cross-cutting. It's a transdisciplinary and transsectoral collaboration hub. And it's really a hub for co-design and co-creation, and very much based on data-driven innovation. And as we outlined here, there are loads of adjacent activities around the AMR Futures Lab, and Futures Lab is connected to a lot of academic research, implementation partners, and global partners. And as such, today we're really intending to, or today is the continuation of our intention to link further with nurses and midwives as major stakeholders in this innovation context. So we have a prize, we have a competition, and just to mention again what the prize actually is at the end. I mean, the pathway is already a lot pathway on setting up ideas and participating in webinars is already a lot of win. But we are really looking forward to your submissions. And we would like to pick things up by mentoring and developing your idea further. And finally, there is also created an opportunity for a study visit at the healthcare centers in Bangalore, in India. Now, and with that, I would like to wish you good luck and hand over to Manish for a further introduction of our speakers and further words.
Thank you, Till. It's a brilliant background what you gave, and I think most of the audience would understand where we come from and why this whole nursing challenge has been set up to encourage more nurses. And in that line, I would like to introduce our first speaker, Dr. Abdul Ghafoor, and he is a renowned infectious disease specialist and a senior consultant at a leading hospital chain in India called as Apollo Hospitals. It's not only that, he is a brilliant person in the field of AMR. He has been working in antimicrobial resistance, tropical infections, clinical microbiology, and also has played a key role in global efforts against antimicrobial resistance and managing complex infections in oncology patients. And to top it, he is the one who was the man behind the Chennai Declaration, which made waves quite early on in India. And today, I have requested him to speak to the audience, who are mostly nurses, from an ID perspective. Because he's specialized in ID. So how he would relate that to the nurses to get engaged in addressing AMR through ID specialization. Over to you, Dr. Ghafoor.
Yes, good afternoon, good morning. Thanks, Manish, and thanks, everybody. Hi, Till. Wonderful. Okay, diagnostic stewardship. Am I supposed to talk for 15 minutes, Manish?
Yes, 15 minutes on ID perspective for the nurses.
ID perspective, fine. Diagnostic stewardship. What is the importance of diagnostic stewardship in infectious diseases perspective? You know, the purpose of stewardship is using the right antibiotic at the right time for the right patient, right dose to reduce the morbidity and mortality of the patients. That's the main purpose of antibiotic stewardship. Of course, as a secondary aim, it will reduce the antimicrobial resistance, local antimicrobial resistance, global antimicrobial resistance. We doctors and everybody, nurses, we all depend on diagnostics, the clinical history, clinical examination, and then the diagnosis to make the right diagnosis and initiate the right anti-infectives. It's extremely important to select the right diagnostic test for a proper diagnosis, and to order the right diagnostic, to carry out the right sample collection, sending it to laboratory, result collection, discussion with the treating doctors and others. Nurses have an excellent role, as a leading role in diagnostic stewardship in the practice of infectious diseases. First, just like the doctors, the nurses should also know which test is the right test for that particular indication. Somebody is coming with, you should not just order blood test, blood culture, or a urine culture. It should be a proper test for that proper indication. We all know that if you just send a urine culture for a diabetic patients, it almost always grow a bacteria. But that is asymptomatic bacteria. In diabetic, we don't give antibiotics. It's a colonization, almost normal. Just like a patient is in the ward, in the catheter, you send a culture, it grows bacteria or a candida. It's only colonization of the catheter. We don't give antibiotic, we don't give antifungal for catheter colonization of bacteria or candida. We don't collect a sputum sample if the patient doesn't have a good quality sputum. So it's very important to collect the right sample, the order, the right diagnostic. Once the right diagnostic is ordered by the treating clinician, the nurses play a very important role to tell the doctor. A doctor may send a blood culture or a urine culture or a sputum culture. The nurses know better than the treating doctors whether the patient is having proper cough, proper sputum sample, proper urinary sample. The nurses can immediately discuss with the ordering or treating doctor, hey doc, this sample is not appropriate. Are you sure you want to send the sample? Please don't hesitate to discuss with the treating doctor. The treating doctor is not with the patient all the time. You nurses are with the patients. You are the one taking care of the patient all the time. And you know much more about the patient than the treating doctor. Doctor may order a diagnostic test based on what he knows, but discuss with the treating doctor whether the test is necessary. Once you know that the test is necessary, after discussion with the treating doctor, you collect the proper urine sample, for example, for a urine culture. You know that how to collect a proper midstream urine. All nurses know the sample collection protocol. You know how to collect a proper sputum sample. You know how to collect a proper blood culture. Junior doctors collect, phlebotomists collect, nurses collect the blood culture. You know that if you don't collect the blood culture sample in a proper way, it will be contamination. And the commonest bacteria in any blood culture, in any hospital is coagulase negative staphylococcus. That's a skin bacteria, a skin colonizer. If you don't collect the blood sample properly, with the sterile precautions, the blood will be contaminated by the skin bacteria and that will grow instead of a real pathogen. So the right sample collection is very important. Once you collect the right sample, you should send the sample to the laboratory in a proper way. For example, if a urine sample for a urine routine or culture should be sent off immediately. And if you cannot send off immediately, you should know how to store it. And if so, how long to store, how a sputum sample can be stored, what to do with a blood culture bottle. You should be familiar with all the routine clinical samples. And then the sample is reaching a laboratory. The microbiology laboratory issues the results. In my hospital, the nurses play a significant role in collecting the blood culture or other culture results. So our nurses, we teach them basic microbiology, the name of the antibiotic, the basic resistance mechanisms like ESBL, carbapenem resistant, colistin resistant, because most often they collect the culture results and tell the doctors. If they make a mistake, we get the wrong report. So we teach our nurses about microbiology, antimicrobial susceptibility. It's very important for the nurses to know all these details. And then inform that to the clinician, and the clinician make the right judgment, the right antibiotic, antifungal, antiviral. Who is administering? The nurses. And administration of a drug is equally or more important than prescribing a drug. Avoid medication error, whether anti-infectives or any other drug. And that's where the role of the nurses and the clinical pharmacists come into the picture. Now, we got a lot of rapid point of care diagnostics. Urinary tract infection. Recently, the Longitude prize, the 10 million pound UK prize. Myself and Till were jury members of that prize. And we gave the 10 million pound for a Swedish company. Amazing rapid point of care diagnostic test. And there are multiple other rapid diagnostic tests, especially 2 or 3 other amazing UK companies have developed rapid point of care diagnostics for urinary tract infection, throat infections, wound infections, even for blood culture. And rapid diagnostic tests play a tremendous role in future for infectious disease management. And who does the rapid diagnostics mostly? In a GP clinic, the nurse. In the hospital, the nurse. And you nurses will play a leading role in diagnostic tests in the future, especially in the case of rapid point of care diagnostics. And you are the one collecting the sample. You are the one doing the testing. You are the one interpreting and giving that to the doctor. So all the nursing students and nurses should be familiar with the basics of antimicrobials and the microorganism. You play a leading role in antibody stewardship. And antibody stewardship is one of the most important measures to reduce local and global challenge of antimicrobial resistance crisis. And nurses play a leading role in tackling efforts of antimicrobial resistance. Thank you.
Thank you, Dr. Ghaffur. That was, I think, in a nutshell, you could precisely sensitize the significance of the nurses in addressing AMR, because we all understand diagnostics is important, but I think it all begins with the sample collection. If anyone has questions, probably I'll give some time for questions because Dr. Ghaffur has to step out. So anybody has any questions? I'm looking at the chat box. Please don't hesitate to ask any questions because he's here for some time. Okay. If not, then thank you, Dr. Ghaffur.
Manish, I have a question.
Yeah.
I have a question.
Yes,
we can't let Abdul leave from the discussion without having a proper some questions. Abdul, thank you so much as ever. Fantastic presentation, and really thank you for making a case for diagnostics again and diagnostic stewardship. Very, very important, and also point of care testing. And so I mean, you mentioned the Longitude Prize and everything. So it's really important to highlight point of care testing. How much do you see the challenge in delivering the right training for all these point of care tests to the nurses or to people who are doing the test? So we have always a challenge between those who order the test and those who execute the test. And very often in the design of tests, there is too much emphasis on those people who order the test and less so on those people who actually do the test. So training and design of the test. So can you emphasize or allude a little bit more on how we actually engage with nurses to do that?
Yeah, excellent.
Dr. Ghaffur, before you respond, yeah. There are 3 more people who are asking questions. So, you have 3 more to answer. So go ahead.
Right, I'll make it fast. Still, there's a wonderful point. When we were the jury members of the Longitude Prize, I'm sure we know the criteria, the simplicity of the test, the ease of doing a test. If a test is complex, it is not an ideal rapid point of care diagnostic. We should train the nurses. And, I was discussing, I'm an advisor to one of the companies. We were discussing about the pipette. How easy to hold a pipette. If it is difficult to pipette, that's not a good rapid point of care diagnostics. So ease of doing the test, that's a responsibility of the engineers who design the test to make it very easy to do. If a rapid point of care test is complicated, it's not a proper rapid point of care diagnostic test.
Thank you.
Thank you.
So I'll go to Laura. So you could unmute it. Yeah, please go ahead.
I really enjoyed that talk. Just want to say thank you very much. I love your enthusiasm. I just wanted to say as well, coming from as a nurse advocate, is that I absolutely think it's right. And I think we really struggle at times to get high quality diagnostics, especially with a blood culture. We're not getting enough blood so I think really going back to that training and how we can really teach nurses on how to get high quality diagnostic tests that are reliable, because actually that's the catalyst of what happens next in going forwards, isn't it? And also, again, how can we then enable our nurses to have a much bigger voice in patient care, because actually they are the ones spending the most time with the patients, but actually it comes down to clinical decision, and there's that fear of what if the patient gets sepsis, what if the patient goes off, we'll just give this. So how do we combat that sort of culture and behaviour, and let the nurse say, well, actually the patient is doing much better, and really come forward with that opinion. It's just a thought, but I thought it was a brilliant talk. Thank you.
Yeah, Laura, excellent. Thanks for the comment and excellent point. We need to empower our nurses in antibiotic stewardship and, most importantly, infection control. We cannot implement infection control in the hospital without nurses' active participation and leadership.
Yeah. Sorry, can I just sorry, I won't go on, but I think you made a really good point. We have very specialist nurses doing infection prevention and control, but in my personal opinion, I think it should be a core skill of nursing and what good nursing care looks like. So I think that'd be my vision, but I know currently we have very specialist teams within our organisations delivering infection prevention and control.
Thank you. So, Dr. Ghaffur, we have 2 more questions in the chat box. One is Rocky saying that I'm in a country where nurses don't get the opportunity to make core decisions. What are some ethical dilemma scenarios you can recommend in the case of a mistest or a misdiagnosis?
Okay, whether the nurses can order the test, usually doctors order the test, but the nurses again should be empowered to order the test with the whatever based on their training. If a nurse is very well trained, we should not hesitate to empower the nurse to order the test. In UK, there are nurse consultants. They can order the test. But again, they are very well trained. They know very well what they are doing. So if your nurse is well trained, empower the nurse and give the freedom to order.
I think, yes. The follow-up question is from Ariani, who asked, how do you empower the nurses?
How to empower the nurses? Okay. The empowerment, we got a better example in the field of infection control. We always tell our nurse, however senior a consultant is, however big boss of the hospital is coming to the ward, don't allow that person to touch the patient unless use alcohol hand rub. Now, if you tell that to a junior nurse just joined last week, that nurse will be, I can't do that. I can't talk to a senior consultant. But then we always quote the example of UK, where the nurses are so empowered, we consultants are afraid of the nurses. We're literally afraid of the nurses. And we should have the same thing here. Don't be afraid. You are empowered. You be bold enough to talk and instruct a senior doctor or administration. And we need to give that courage to the nurse. You can do it, and we are there to protect. Brilliant. If something goes wrong.
Brilliant. Thank you so much, Dr. Ghaffur, for this insightful, not only the perspective, but also the encouragement that you gave, and taking the example of the UK, how one can be empowered in, exercising their rights towards the patient's safety and preventing antimicrobial resistance. Thank you so much. All right, now we move to the next speaker, Dr. Raksha Bhatt. Dr. Raksha, she's a clinical microbiologist, and she has an amazing experience of more than a decade in infection prevention, control, and antimicrobial stewardship practices. And she's also a FIMER fellow, which is a Foundation for Advancement of International Medical Education and Research. But there is a commonality is she's an alma mater from the same university where I studied my master's from way back in the early 90s. But over the years, she has learned that meaningful impact of infection prevention, control, and AMS is achieved not through silos, but through strong interprofessional collaboration, especially with nurses and the bedside. I think that brings in a great message from her perspective itself. So over to you, Raksha, now. Thank you.
Thank you, Dr. Manish, for that warm introduction and for the invite to participate in this event, because I believe that the best of the stewards, at least the ones whom I have worked with, were my infection control nurses. Wherever I have worked or whatever I have learned regarding IPC or AMSPs through them, especially the real world challenges. I have a small presentation to start with. Just let me know if it is visible. I will start sharing my screen right away. I'll go on full screen mode right now. Yeah. Are the slides visible to all of you?
Yes, we can see it. We can see it.
Yeah. So I'm going to talk briefly about the role of nurses, especially with regards to diagnostic stewardship, which Dr. Abdul has briefly covered in the previous 15 minutes. Now, when you look at the diagnostic cycle pathway, when a clinician decides to order a test and then lists out the tests that are needed for diagnosing an infection, the first person who interacts with the patient for the sample that has to be collected and it is to be transported to the laboratory, it is the nurse. So the interactive element here is the people component is the staff nurse who will be interacting between the patient, the clinician, and the laboratory. And once the test sample reaches the lab, the processing happens in the lab, and again the interaction with the technician is through the nurse. And once the test report is generated, the report is first seen by the nurse. So, what I'm trying to highlight here is the central core of this entire diagnostic cycle would be a staff nurse in your institute. I hope all of you agree with this concept. Now, we are all aware of this antimicrobial stewardship and diagnostic stewardship and the infection control stewardship model, the AID model. If you look into the depth of this triangle, actually, there are overlapping areas here where you have the antimicrobial stewardship component which interacts with the diagnostic stewardship, then you have the infection control stewardship. So if you look at each of these areas, all our staff nurses have overlapping roles with all the team members in your healthcare institute. Now, what are the real world challenges? We could see the questions coming in that there are ethical dilemmas, there are things like how do we empower them. Let's delve into some of these issues that we have. There is pressure on the nurses to just send the sample. The tests are ordered, and in a reflex, the samples are being collected. Whether a clinical criteria is met or not is something which the nurses wouldn't delve into, really, right? And there are time constraints in a high acuity settings coming from different countries and different backgrounds. We know that our ER and ICU loads are very different, and there is limited time to think of about the sample type and the collection. And also there is inadequate training on specimen quality. The focus would be on sending the samples to the lab and not whether it has any diagnostic value. And also there is unclear or inconsistent test indications. The indications wouldn't be clear or the standardized criteria wouldn't be met. For example, say urine cultures would be sent as a part of a panel, or a C. diff test would be done because the patient is having diarrhea, probably 1 or 2 episodes, or repeat cultures are being sent. And also there's a fear of questioning senior clinicians. That's what we're talking about right now. So this hierarchical concept of ensuring that only doctors order the tests and the nurses are going to collect the reports, I think that has to change for us to talk about stewardship practically. Then there is poor communication between the teams within a hospital. Limited interaction with microbiology and stewardship teams can reduce the feedback loops. Also, there are logistic barriers like delays in transport, probably wrong containers being collected. For example, say you have a formalin container for a culture sample, or unavailable supplies which might affect the sample integrity. Also, there's a lot on documentation gaps. Many of our hospitals are still writing manual reports, and they may not have a HIS or LIS system, information system. So there are a lot of missing clinical details which are very important for stewardship initiatives. So that reduces the interpretability of the laboratory results. And also there's an over reliance on protocols without context. We all have accreditations, audits, lot of checklists. So the common complaint that many of our nursing staff would give us, we have a lot of checklists to fill. So that kind of overrides the bedside clinical judgment. And more importantly, we lack recognition of the nursing role in diagnostics. We consider diagnostics more so of a clinician domain, or doctor or a lab responsibility. and not a shared one amongst all the team members. Now let's go to some brief cases. So we had a 55-year-old patient with sepsis admitted in the ICU. Broad spectrum antibiotics are planned. I'm pretty sure many of us would have seen this day in and day out. But blood cultures are required first. So what is the nurse's diagnostic stewardship role here? The nurse can ensure that adequate blood volume can be collected, that is 10 ml, and you don't just fill the bottle partially. You ensure you collect 2 sets from different venipuncture sites before starting antibiotics. You use strict aseptic techniques to prevent skin flora contamination. You document the time, site, and volume collected. So what is the stewardship impact a nurse can bring in here? Higher pathogen recovery rate, reduced false negative cultures, and you prevent unnecessary escalation or prolongation of antibiotics. So there is a diagnostic stewardship component, there is an antimicrobial stewardship component here. Let's go to the next case. Now, this is an 82-year-old woman with incontinence and delirium, suspected to have a urinary tract infection, and the urine culture grew Pseudomonas aeruginosa. This actually happened 2 days ago in our institute. So, the nurse role in this diagnostic stewardship here. So, we called back and asked, was the sample collected properly? Was aseptic techniques followed? So, you can recognize that poor collection technique can introduce environmental organisms. Avoid urine collection from diaper or bedpans. Ensure that proper perineal cleaning before midstream collection. A very important part is the patient education part here. Who does that? The nurse does this, isn't it? So if catheterized, ensure that you collect the urine aseptically from the sampling port and not the bag. And more important, always question the patient if he or she has a urinary symptom or not, or is it just a reflex urine culture collection. So what is the stewardship impact a nurse can bring in? You can prevent mislabeling, colonization, or contamination as infection. You can avoid unnecessary anti-pseudomonal antibiotics. You can reduce the antimicrobial resistance pressure. Now this is another case, a third case. A patient is on antibiotics. He develops loose stools on the day 4 of admission. The treating unit requests a C. difficile testing. So what is the nurse's diagnostic stewardship role here? You can confirm with the patient and inform the doctor whether 3 or more unformed stools are there in the last 24 hours. What is the consistency of the stool? Is it liquid, unformed, not formed stool? Many a times we receive samples which are very solid stools, and they do ask for a C. diff testing. So checking the adequacy and the quality of sample is another important part which the nurses can pitch in and contribute whether the sample is adequate for testing. You can check for the recent laxative use, which may explain the diarrhea. You can coordinate the prompt stool transport to the lab. You can initiate contact precautions while awaiting results. So what is the stewardship impact a nurse can bring in such cases? You can avoid false positive results from colonized patients. You can prevent unnecessary isolation and treatment. You can support accurate infection surveillance data. Now, with these 3 cases, I just tried to show how all these 3 stewardship components are interacting with each other and how a staff nurse in a hospital can play an important role in connecting and coordinating with all the different team members. Now, let's look at a SWOT analysis, a strength, weakness, opportunity, and threat analysis of the role of nurses in stewardship. Now, what are the strengths of nurses? The nurses are the ones who are the closest to the patient. They are the gatekeepers of specimen quality. We saw through these cases that how a staff nurse can look into the quality of specimens. And I believe that they are custodians of pre-analytical integrity. Unless the sample passes through the nurse who collects it properly and then it reaches the lab, we cannot trust the integrity of the reports by itself. Now, let's look at the weaknesses. We were talking about the training component. We know that diagnostic stewardship per se, there is limited formal training for nurses. So we need to invest in diagnostic reasoning and integrating this into the curriculum across various settings. We also believe that the high workload and staffing pressures contribute to this lack of initiatives amongst the nurses into diagnostic stewardship. Also, the lab nurse feedback loop can be weak because of all these issues. Now, let's look at the opportunities that we have. Nurses are the best bedside diagnostic stewardship champions. Also, we spoke about the point of care tests. I believe that the recent POCTs which have come, once they are out in the market and we look at the ER or the OPD clinics, Once the patients start coming in, I think there needs to be a quality control component and training, a continued training component amongst nurses to analyze the specimens, to read out the reports, because they are going to replace the lab personnel who are doing the tests. This is again a upcoming area. I think we need to invest a lot in training the staff nurses on these POCTs. And there is a large amount of investment that we can do in integrating these diagnostics with IPC and AMSP together. Now, what is the threat? We know that we talk about laboratories and all the technology, but the nursing role in diagnostics is again under recognized. Also, you might have noticed that if you have a wrong sample or a wrong report, always there is a blame culture around sample errors. The lab would blame the nurse would blame the lab, and finally the clinician would blame the both of them, right? So this blame culture needs to stop. And also, the technology adoption that we are talking about has to be done only with adequate training amongst all the staff nurses, the technicians, and also the clinicians. So this is a approach that I thought that would work best for us to develop any kind of projects with in relation to considering nurses in diagnostic stewardship. So just to summarize, I think the correct collection, then the correct transport and handling, correct processing, correct interpretation, then is correct diagnosis, then we have correct treatment. All our staff nurses play a very critical role in this diagnostic workflow. So this is just an acronym that I made for all of you. Nurses are the backbone of diagnostic stewardship. So what is N? The need for test. Always ask, does this test add value for this patient right now? Assess the clinical indication before sampling collection. I think we need to empower our nurses, not just verbally, but also on paper, whether they are empowered to order these tests. I think some amount of training and empowerment on paper also helps in giving that authority for the staff nurses to order tests. Next is use the right specimen and technique, the correct sample type, volume, container, and aseptic methods to be followed. Right timing, collect the sample at the right time, say before antibiotics, and also in some cases, like if you want to collect a sputum sample for tuberculosis, collect an early morning specimen. I think these nitty-gritties have to be kept in mind while ordering the tests. The requirements have to be taught well to our staff nurses. Then comes your S, safe transport and documentation, prompt transporting, accurate labeling, and also mention all the clinical details so that the lab can understand what exactly are the doctors or the nurses looking for diagnosis in this patient. Next is E, evaluating the results in clinical context. Once the report is ready, you can recognize whether it is a contamination, colonization versus infection, and escalate the treatment or de-escalate also appropriately. Now, this post-analytical component, we lay a lot of focus on training the clinicians. I think with empowerment of nurses, we also mean to say that the nurses should be empowered in this component as well. That is interpretation of the clinical reports so that the report is of some clinical utility for the patient. So thank you for this opportunity to interact, and I am open to questions. I'll stop sharing right away.
Thank you, Raksha. I think this was a brilliant presentation, which not only speaks about the techniques part of it, it brings out the vast experience you have had practically in diagnostics as well as an infection prevention control officer, being a microbiologist. That's brilliant. So
thank you, sir.
We have the first question from Laura. Laura, probably you want to ask it to yourself then, which you written the text.
Oh, yeah, sorry, I thought it was a fantastic presentation. Thanks very much.
Thanks, Laura.
And you really sort of sparked thoughts, but my brain was going all over the place. But yeah, I was just thinking, we get these patients coming in who have C. diff, and I'm just wondering whether we could risk assess these patients on further admissions so that when they come in again, we can say, take a history, you had C. diff previously, let's really take that into consideration on what antimicrobials we're going to use moving forwards to prevent this happening again. What are your thoughts on that, please?
Yeah, what I understand is, see, when you're talking about secondary infections like C. diff, you always have the history component of the patient, like previous admissions or previous antibiotic exposure. So that becomes important when you are trying to, like, look at the infection control part of cohorting the patient and then starting them on appropriate therapy. When you talk about getting that data, I think the nurses play a very critical role in getting this data out, and also ensuring that there is no transmission happening in your setting. So you have the diagnostic component there of C. diff, where the history taking and ensuring that that data is conveyed to the team, and then the infection control part. I think the nurses there can use tools. There are a lot of tools that are now available. I have personally used some C. diff risk scoring systems. There are AI apps that are available which you can integrate into your HIS system. There are C. diff scorings that are available that you can use. I think technology can also be pitched in there. It's an interesting area to research on, because what I feel is when we think about a project or say a training your staff nurses, you need to integrate different components. There might be a new POCT in the market which says this helps you in C. diff scoring, you can use that. But unless you train your nurses on using that, or tell the lab that no, there is a new system that we are using, they might be traditionally using a card test, a C. diff card test, or a C. diff PCR. I personally have faced this in my institute. We still use a C. diff card test. We do have a C. diff PCR, but the diagnostic algorithm is not very clear. So the clinicians are not aware when to use the CDF PCR, and when the patient needs a retesting. I think that training component to the staff nurses is very, very important with regards to deciding when to order the test. Second thing is, once the report comes, how do you interpret that? And then the infection control part. So I think first thing would be training. Second thing would be investing in technology, and third thing is educating all staffs, not just the nurses, doctors, technicians, on using these scoring systems and newer technologies to ensure that your C. diff is within control limits within your hospital.
Yeah,
Thank you.
Yeah, thank you. Sorry, can I just ask another quick question? Just
Sure, Lara.
sorry, I do apologise. Just the other thing is, I'm thinking about is that we've really exhausted and we're doing really well in looking at getting the right diagnostics. But I'm just thinking, I work within COPD respiratory and looking at the source of these infections. So if you've got a patient at home who's got a nebulizer mask that they haven't changed for 5 years and they're getting multiple infections, a nurse has got a really good role in, really digging into that history and knowing actually, because they might be the person going out to that person's house and seeing how they're living. And, if they're not changing something very simple like a nebulizer mask, then actually that could be the source of why they keep getting all these recurrent infections. So I think documentation is a massive, and not just being writing it down, but being proactive in how they're challenging AMR. So no, thanks for that. It really sort of motivated me as well.
Yeah, thank you.
Thank you. And we have two comments in the comment section from Shalil and Kwagala Timothy. But overall, I think we have to get into the next session now with Camellia. So thank you so much, Dr. Raksha, for this brilliant presentation and this interaction
Thank you,
that you
Dr.
had.
Manish.
Very, very
Thank you,
meaningful. Okay.
Yeah.
Thank you. So over to Dr. Camellia Bocat. Welcome to this session, and she's going to speak now. And before that, I'd like to give a brief introduction. She is a registered nurse and with a master's in nursing, and also interesting two things are she's a member of the Infection Prevention Control Technical Committee, and which is on the HSO, the Health Science Organization. Also, has been on the Hand Hygiene Working Group, which brings of the BAPCOC. And I think these kind of backgrounds would enrich her presentation in her background and an experience. And for all the nurses over here, you being a nurse yourself, I think you will add more the intense dimension to what you're going to share with all of us now. Looking forward to you.
Thank you. Thank you very much for the introduction. Can you hear me, all of
Yes,
you?
we can.
Yes.
We can hear you.
Yes. Okay. So there are already have been told a lot of interesting things, a lot of interesting aspects. So I will not dive into those again and repeat what has already been said. I will tell you just a few aspects from my own experience. So as Dr. Manesh told, do I say it right? Manish? Yes.
Yes, yes.
Said I'm indeed. I worked for 10 years on an ICU in a Belgian hospital, a Belgian acute care hospital. Then I worked 6 years on neurology and OR for the DBS patients. And the last 5 years, I'm working as an IPC nurse. As an IPC nurse, it was really interesting to start. I find it a very challenging job, at least. And
Yes.
we thought about it last year to try to merge IPC and AMR in our hospital, to create a hybrid nurse who is doing IPC and AMR in the same hospital. There have been challenges because as you may already know, and as was the question after the first session, what we do in countries where nurses are not allowed to ask questions and to say many things. Well, you don't really have to go far from the UK. I mean, in Belgium, we also have a very aristocratical culture, so to call it. I'm not a native English speaker, so you will hear probably a few things that you don't hear in other speakers. But let's say in Belgium we have really that social classes built up in a hospital, where the physicians are like the nurses and the executors. It was really a challenge to present the idea of creating a nurse who is promoting also AMR and IPC at the same time, and a nurse who dares to ask questions to physicians about antibiotics, about switching from IV to per oral antibiotics. One advice that I can give you from my experience: start with the easy steps, start with the low-hanging fruit. As it was already mentioned in the first two talks, about sampling. Sampling is something that it's done by nurses. Sampling is something that you can improve even without many budget improvements or other projects. Once you start with interest in sampling methods, with interest in timing your medication, with doing everything right that you do as a nurse, then you can gain some trust from the physicians and to start to cooperate in more difficult and challenging aspects. I prepared a short presentation for you, but a lot of things were already said. I will just try to, share. Let's share my presentation. I will not give you the whole presentation because that would be a lot of repetition.
Yes.
I'm not sure what you are seeing now.
We see a whole screen, so yes.
Can you see now the presentation? And
yes.
Now in presentation mode?
Yes, now it's a full screen.
Okay, just like that. I prepared the presentation because as I said, I'm not a native English speaker, so I thought maybe I will be a little bit impressed or intimidated by this webinar. So why AMR? First question. Well, you can take it as a rational reason or emotional reason about collapsing of modern medicine or return to the dark ages, where you can not treat infections, you don't have the any more antibiotics that are working against the challenges that you meet, then why involve nurses in the AMR, as the physician said, and as you know as nurses, and I know as nurses. I mean, we have different settings in a hospital: emergency, operating room, discharge, cardiac monitoring. There is one constant. The constant is maybe two constants: the patient going through the whole circuit, and the nurses. The nurses are present everywhere. So it is important to recognize, to try to use this circuit also in AMR. So why? Because we are everywhere, the nurses involved in the patient journey in the hospital. And there are a lot of things that has been already said, but I think that it's an important one. We are really the persons patients are trusting, and we are really able to do some patient advocacy because we are driven by a goal of providing the best care. So this is why nurses should be involved in AMR, and we are also, as you have seen in the previous picture, here are nurses with the same colors and like are the same, but nurses are not really the same. We are really having different specialties, different expertise. You have the bedside nurses, you have antibiotic champions, you have leaders, you have specialized teams of nurses. So let's try to use those nurses and resources that you have within your hospital. And there are some elaborate points that have been mentioned about what you can do as a nurse. When the diagnosis are taken, how antibiotics are administered, whether therapy is reviewed, how long treatment continues, what patients understand when they go home. And this is actually all these 5 points are daily nursing work. And the physicians already explained this. So I think I will just jump to my last 2 slides, because I also prepared a lot of evidence. Try also to dive into literature to see how in other places they try to tackle these aspects of nursing-driven stewardship and the results that they obtained. They are really, really nice studies about this kind of projects and multimodal interventions, and how actually as nurses we can really help and support AMR actions in our daily tasks. So I think I have, just to close my talk, 2 important questions. As from a nurse to nurses, I think you should ask yourself, where does our antibiotic pathway fail most often? Just ask yourself for your own facility. Is this in diagnostics? Is this in timing? Is review, is switch or duration a problem? What is causing our problems or most problems, and how can we resolve that? Because you always have to focus on what in your institution is a problem. And a second question that you should ask yourself, what can we change today, even without a new budget? Because as we know, new budgets and new projects are sometimes taking a lot of time, and you don't get them, or you get them, but they are really sometimes like very easy interventions that you can follow up upon, that you can implement within your teams and wards to improve the way you work. So you don't really have to reinvent new policy. Maybe you don't even need new budgets for this, but you need, first of all, awareness and communication within your teams and facility. So this was my presentation. I don't know if I can provide this to you, of course. I don't know if you have questions or
Yeah, thank you, Camelia. It was brilliant presentation. I mean, your slides were very, very informative, and the graphics were communicating very well what you
yeah,
were
I really tried
intending.
to.
It was very nice. Though you say you are not a native English speaker, you communicated very well the whole principles of it, and I think it also endorsed from a nursing perspective what the clinician and the microbiologist spoke earlier to you. So now I'd open this for questions from the audience. If anyone has any questions, please don't hesitate to ask. We have still 5 minutes before we close. In the meantime, over to you, Till.
I see Laura has a question already. I was expecting that. Go for it, Laura.
Great,
Oh,
Laura.
don't apologise. No, don't apologise. Just want to
No,
say
it's nice. It's nice that you're interacting and making the discussion more, vibrant. Thank
very
you.
motivated this morning. That was a fantastic talk, and I think you highlighted some really key aspects there. I absolutely believe that this doesn't need any more money thrown at it. All it needs is working differently. We just need to use our workforce differently to get around this problem. So educating nurses, and actually I believe they are the unknown force that could actually catalyse the change. So we don't need a load of money. We just need to change the education, change the way we do things slightly, and adapt. So thank you very much for that brilliant talk.
Thank you.
I actually have a question, Manish, if you allow. So, Camelia, thank you so much for the presentation. And I was trying to capture your rapid slides to get the content, because they were fantastic, and it would have been fantastic to see them in full, but we don't have time, and it would be really nice if you could share them. But one thing I grabbed at the end, I saw, and at your on the board where you tick board, you tick questions off. There was one section where it says patient understands antibiotics. It wasn't ticked off. And I wonder why you haven't ticked it off. Is this a challenge? And if so, how do you communicate antibiotics with patients? Can you allude a little bit about this? Because that's an interesting topic.
Yes. So I didn't tick that off because we are still have a long way to go in our facility for that one. We started last year with educating patients to perform hand hygiene and to really empower patients in hand hygiene. And we are thinking about antibiotics but it's really much more complex, and we need a lot of teaching materials still to be developed. We have many patients who are not native Dutch-speaking patients, so we always have to think about developing learning or teaching materials that are more visually developed than a lot of text. So that is something that is still in a project of development phase in our facility. So I cannot get that off, not yet, for our organization. And I think it's really an extra challenge to overcome, to get your facility to support you, to allow you to empower patients. It's not only about as a nurse, you probably want to empower patients, but does your facility think that patients should be empowered? Because it's a dangerous place when you give information to patients, and the patients know how things should be done, and they see that they are not happening as it is presented in our teaching materials. So we had a few discussions here in-house, and I really tried to get them to both feet on the ground, our management, and to say our patients are Googling the whole day. Our patients are looking and seeing. They don't live in a tree somewhere isolated. They are persons interacting in the society, and they hear and learn things. So when they are admitted, they know what they know. So let's not try to treat them like maybe 100 years ago, that information, or we are the only persons to decide what a patient is allowed to know or not to know, you know. And instead of that, fear of patient empowerment, let's try to create things so that we are giving the right information and the feasible information. What can we do in our facility for patients and how we do that here? It's also not all science fiction and American dream in our hospitals, you know. We have budget cuts and we have problems that we have to like be creative and to find another way to do it.
Mm-hmm. Fantastic. Thank you, Camelia. Laura, I see your hand, but we need to close very soon. So handing over quickly to you.
Yeah, really quickly. And just on the flip side of that, we see patients that are demanding antibiotics. So you've got the other flip side of, I think we should educate them because actually they come to the hospital, I want antibiotics. If you don't give them, they buy them off the internet. The internet's a nightmare at the moment because they can buy oxygen, antibiotics and whatever they need. So I think moving forward, I absolutely get what you're saying, but they come in asking for them and we'll get them other ways if you don't give them. Thank you.
Tremendous. Thank you so much. Yeah, I don't see any further questions anywhere, any hands. Manish, I think we need to wrap up.
Yes.
Fantastic. So, yeah. Right. So, I really would like to take that opportunity now to thank, first of all the speakers of today. So Dr. Abdul, Dr. Raksha, and Camelia for their presentations. It was wonderful, and a big round of applause, please, virtually. Really, it shows the opportunity we have here, the need, the opportunity, but also the breadth of expertise which is there in the field, which is contributing, and which this initiative really strives to do, connecting and sparking conversations and sparking ideas. And those ideas, now you're a challenge with that, need to be converted into, or we're inviting you to convert them into your concept notes and your submissions. And I would like to ask Hannah to bring up a slide where we again have the submission details for the challenge. And while Hannah is doing this, I really, really want to thank Hannah and the team of the Nursing Now Challenge for all the support they did for us in setting up these webinars and making all this happen. And from now on, of course, we will be handling further all your submissions. But Hannah, are you going to share? Yes, here we go.
There you go.
Very good. So can see here, you are invited to submit a concept note. And this is where you describe your idea for an innovative nurse and midwife-led AMR project to be implemented in your workplace or community. Remember, AMR Futures Lab, the objective is to look at the implementation. So this is what we're all about. Why we're here. We have the guidelines from the Nursing Now Challenge. You see, this is not much you have to write. You have up to 1,000 words. And there is a deadline, 30th of January. So it's around the corner. And there is the submission, which you can do by an email. So take that. Please go forward with your submission. We are looking really forward to receiving loads of submissions and really reading them and then looking for a winner. And I'm sure there will be many. We are all winners already by attending and participating in these webinars. I learned a lot and I enjoyed them a lot. And I joined the conversation, the questions. Laura, thank you so much for asking many questions today. Manish, a few words from your side before we close.
Yeah, I think it was a brilliant conversation today with all three dimensions, starting from a clinician, ID physician, to a diagnostic person from the laboratory, and also as an infection prevention control officer, and then coming to the nursing, who could. The whole story became complete today. It was very brilliant. Thank you so much, all the speakers and the questions which came from the audience, and especially Laura for making the questions more interactive and connected. Thank you so much.
Brilliant. Thank you for joining today, and thank you to the audience. And see you soon. Bye-bye.
Bye-bye.
Bye. Bye.
Bye.
Thank you, everyone.
Bye-bye.
Bye.
Bye. Thank you.